Thank you. So, I am going to next 10-15 minutes quickly, because we are running late, I think, for the inauguration part also. I got a message from Manoj. So, I'm going to talk about the sulfonylureas in this era of SGLT2s, DPP4s, GLP, 2G, triple G, all that, and whether the value in our country does it stay. These are my disclosures. And we know the diabetes around the world, 3 out of 4 adults diabetes live in low socioeconomic middle income countries, so called, and about it causes at least USD $966 billion as healthcare expenditure, and it's responsible for about 6.7 million deaths. And what's alarming is that this 87% of these pre-diabetics and diabetics low and middle income regions are one comprises of this. So that's something to worry about, because the cost implications, the economics will be huge burden on this low and middle income countries. More than 25% increase in Indian people with diabetes is expected by 2030. That's something to be worried again. And of course, it is the burden which we are trying to create without involving the primordial prevention and the primary prevention, which most of us fail to recognize the pre-diabetics. The recent ICMR clearly showed the pre-diabetics focus the diabetics. And this is another disheartening values of A1C in our country, and all of us are part of this because of this inertia which most of us have. Look at the baseline A1Cs in all these clinical trials, which are all the Indian data. It is about 7.9 and an average, and that's where the sulfonylureas play an important key role in controlling this. Of course, the last 3-4 years back, we have moved on from a glucocentric to the patient-centric approach, and this is what the patient-centric approach says. First time it was way back in 2022, which talked about the glycemic control, the weight and glycemic control, the CV risk and glycemic control, and of course the cardiorenal protection and glycemic control, how we can impart this to our patients. Last 3 decades have been great for us as far as the newer drugs are concerned, but in spite of all these newer drugs in our armamentarium, the A1C still lies at 7.9, and that's very disheartening, because the onus, I completely believe it is on us, that we don't take care of our patients, we don't educate, we don't categorically say. The common notion which patients come for window shopping, sir, the doctor has prescribed me 3 drugs and he is telling me to go on to insulin, example, and we say no, you don't require insulin, we'll try to retain that patient by saying 4th, 5th drug we had, and we know that 4th, 5th drug wouldn't bring down his A1C to 1 or 2% down. So you need to be very categorically telling when the previous physician has treated and told him to board the 3rd drug or the insulin, we need to also echo the same thing, and that's how we need to. That is the first inertia I see, that a GP refers to us and we try to hold the patient and say, no, we'll try with the 3rd, 4th drug, not the insulin part. That's one of the examples which we face in our common scenarios. Please do not say that. Whatever the previous physician has told, if it's guideline based therapy, you should reiterate the same feeling from your pen as well, and then the patient sticks on. So this is what in the last 3 decades we have got, and I've been lucky to be part of a lot of these drug developments, starting from the DPP4s to SGLT2s to 2G and 3G. Currently I'm doing for retatrutide the phase 3 trials also. Now gliclazide has got a very long history. I think in the First World War the sulfonamides were used for the wound as antibiotics, and those were found to have hypoglycemia. So that's how the anti-diabetic properties were invented, and you can see the gliclazide was in the market from 1972. That's when the RSSDI also was born, and glimepiride was in 79 patented, but it came to use quite late in 1995 when we were all in MD students. In fact, I still remember one of the VIP patient came down to our hospital for something else, and he was on glimepiride, and my teacher did not know. He said, you have to study about this molecule and present to me today. This was in 98 and 99, and that's how it is started, and of course it's been the longest issues among the modern sulfonylureas. Now, just to tell about the sulfonylureas as the most prescribed treatment in our country and worldwide, you can see there, this is what the data says. Metformin sulfonylurea, it is the commonest prescribed second line, that is to the tune of 30% after monotherapy, and as a combination, as you can see on the right hand side, the therapy is 30.4 and the DPP4s, and then all the other things come into picture. In the real world usage, again this is the JADE registry, which is Joint Asia Diabetes Evaluation. About 11 Asian countries were taken into picture. About 62,000 patients were studied. In this, 60% of the treated patient received the SU based therapy, and that's something which is reiterating, especially in the Southeast Asian countries. I think in Taiwan, till today, it is the first line, it's not metformin, it is your sulfonylurea as one, because they say they are not insulin resistant, they are insulinopenic. So that's why that country has got, and of course in China and Japan also the metformin is not used. Real world usage again reiterates the same fact that SU plus metformin amounts to the tune of 80% and DPP-4s to 22%. We all know that when you want the A1C to be reduced, you require a sulfonylurea. There is no doubt about that, and that's where the drugs come into picture. Among these SUs, again, gliclazide worldwide 46%, glimepiride 40%. In our country, maybe little lesser of gliclazide, but that is the longest studied molecule, and glimepiride is about 8% still used. So when you choose a drug in your routine OPD practice, there are certain factors you need to look into depending on the patient: the efficaciousness, the hypoglycemia effect, the weight change, CV benefits, progression of DKD, and of course in our country the cost. So these are the factors which you look into, and if you categorize the drug classes, metformin, SU, TZDs, DPP-4, SGLT2 and oral GLP-1s, you can see the benefits of SUs and the GLP-1s are almost same except the cost part. And of course GLP-1s have got a weight reduction, here it's we say as a weight neutral, and the second generation the sulfonylureas were the longest studied. And this is the classification of SU. The third generation are the modern sulfonylureas we call, because of technology of the modified release or extended release. The key mechanisms, I am sure all of you are aware, they stimulate the insulin secretion by acting on the beta cells. They bind to the SUR1 receptor, and that's where the catch of these are very highly specific. The subunit of the ATP sensitive potassium channels on the beta cell membranes, and they depolarize the cell membrane, and thus the calcium influx, and there is a exocytosis of insulin granules. Then let us look at the glycemic efficacy, CV safety, renal outcomes, and hypoglycemia evidences. This is what the category which we were talking about in the earlier slide. When you choose a molecule, these are the aspects you need to look at. Now coming to the efficaciousness, this is a meta-analysis. You can clearly see the gliclazide is shown to be about twice more effective than the DPP-4, about 3 times more than the SGLT2. All of us know SGLT2s are good as far as the cardiorenal benefits are concerned, but when a patient comes with a very high A1C, you need to tackle the A1C first and then give the cardiorenal protection, not the other way around. Keeping A1C at 9% and prescribing SGLT2 doesn't make any sense, because he is not definitely protected. So later on, the trials, now the evidence. Now this is one of the earliest trials, advance and advance on. There was an extended trial also, and of course there are about 470 patients from India as well. This was published way back in 1998. One of the earliest trials to show that this is of course the inclusion exclusion. We are talking about 11,000 plus patients. The first diagnosis at the age after 30 years, and A1C baseline was 7.5, and there is an advance on BP arm also, and that was 145/80. And the additional risk for vascular events, history of any major micro or macrovascular disease, other major risk factors for vascular disease. This is how it was conducted. 11,000 plus patients, 8 years duration, and what did they find? Gliclazide. There were 2 arms, of course, the standard of care and the intensive arm. Gliclazide clearly showed, irrespective of the BMI, the age, the duration of diabetes, and the EGFR levels. And that's last column is very important, because those days we didn't add about this CVOT trials or the cardiorenal, which all came after 2008 rosiglitazone episode. So before that we never had this, but even on those days this was very well studied. Even today this is one of the landmark trials which are taken for reference in many of the studies and comparisons, of course. The outcomes, you can see there is a mean A1C reduction of 7.3 to 6.5 in the intensive arm, and micro and macrovascular to the tune of 10%. This was one of the earliest trials before all your SGLT2 and GLPs came into picture. Gliclazide in the intensive arm clearly showed the A1C reduction to the tune of 6.5% with a significant 10% reduction in the micro and macrovascular. To bifurcate those, again you can see the all-cause mortality reduction was 7%, major coronary events 8%, CV mortality 12%, and new or worsening nephropathy to the tune of 21%. So, this is one of the trials which showed that the microvascular benefits, apart from the UKPDS, this is 10% reduction in that. Steno 2 showed the macrovascular benefits, but this is one trial which has shown 11,000 patients, 8 years duration, and you can see the reduction of all-cause mortality to the tune of 10%. In the same study, the glyclazide had no overstimulation of beta cells, which is we are worried in many of the occasions, clearly showed that the insulin requirement was lesser in the intensive group. Now, this is just to show you the add-on with the other RCTs very clearly about saxagliptin, sitagliptin, alogliptin, glyclazide, glimepiride, and glimepiride metformin. So, these are the trials which talks, and you can see the number of greens are more with the advanced trial with the glyclazide, and you can see the number of patients also. Ticozide 14,000, but it proved CV neutral, nothing mortality wise, no benefit. But advanced, you can see the greens. Accord was with the glimepiride, and this was one of the trials which was closed early because of hypoglycemia and MIs they had in that intensive arm. So, they had to pre-close that study called Accord. And VADT, glimepiride, metformin, insulin, you can see again the CV mortality increase. So, the reduction was seen with alogliptin. I was part of examine study, and this is where you have the advantage with this, the glyclazide, which is SU at no increase at least regarding the cardio safety. So, how does glyclazide stand alone in this era of SUs? So, the structural differences between the glyclazide and glimepiride, that is what contributes to the clinical benefits what you have in the form of reduced hypoglycemia and cardio safety, and that ring called azobicycloacetyl ring what matters. Now, what does it do? It exhibits rapid reversible binding, and that is how you have a lesser rate of hypoglycemia and weight neutrality, whereas other SUs, the glyclazide XR does not activate the EPAC2, which is in the second step after the SUR1, it does not bind to that, and that is how there is a lesser binding and reversibility, that is why lesser hypoglycemia events. And this is just to show you comparison with other ones, the glyclazide got the lowest hypoglycemia risk along the second line generation of sulfonylureas. Again, glyclazide MR has got a lower risk of hypoglycemia vis-a-vis glimepiride, you can see that is to the tune of 70% less reduction of hypoglycemia when you combine with metformin glyclazide, metformin glimepiride. So, as I said earlier, glyclazide is one of the longest studied oldest molecule in the modern sulfonylurea segment, which can give you all the benefits apart from having a CV benefit, cardiorenal benefit. Now, look at this study during Ramzan, the glyclazide and DPP4s have lower similar risk of symptomatic hypoglycemias, which are less than 54, and that is something again re-emphasizing the fact that the hypoglycemia risk is much less with the glyclazide. And of course, there is no weight gain in treated patients with glyclazide compared to the other SUs. You can see the UKPDS, Accord and VADT, they have shown. The glimepiride has given about plus 3.5 in the Accord study, and in the VADT it is given to the tune of 8.1 kgs. So, advanced literally they had no weight gain. What about the cardiac safety? Quickly, this is a cardiovascular safety of glyclazide comparable to metformin, a study, nationwide study which clearly talked about the safety of glyclazide, again 9,000 plus patients with a past history of MI, and the glimepiride versus metformin, and this is clearly shown that the glimepiride had little edge about the cardiovascular risk being pushed into with the glimepiride group, not in the glyclazide group. Again, what is the basis? The SUR1 receptor at, you can see at the beta cell of the pancreas, there are two binding sites, SU and this benzamide moiety which I showed you. That is what characterizes the glyclazide, and this is how there is a minimal risk of hypoglycemia with less beta cell exhaustion compared to the glimepiride, because the single reversible binding to the SUR1, not to the other APAC region. So, the cardiac cells have the SUR2 receptor, and that is how there is no binding from glyclazide, whereas glimepiride also binds to SUR2, both the receptors. And of course, that is why there is a reduction in the cardiovascular risk. I think this is same. Now, let us look at the renal outcome. Again, I am talking about way back in 1998 when this was first published, not with your EMPA-REG or the declaratory trials, which are very recent. This was way back in 1998, which clearly showed that there is a prevention of albuminuria risk to the tune of 30%, end-stage renal disease to the tune of 65% with this molecule, and of course, you can see there is a 20% regression from macro to normal albuminuria. That is the best part. This advance plus, that is the BP arm, again showed the same benefit when you combined with the perindopril, and this was the wonderful study which had both the diabetic and hypertension arm in the same study, and that's the beauty of this, and this is imparting the regression to the tune of 20%. 46% reduction in the ESRD. Again, the advance on was continued beyond 8 years of advance, and they had a better outcomes with the preserved kidney function, as you can see very clearly. This was a 10-year follow-up where it showed 46% reduction in the incidence of ESRD, that is patients switching over to the dialysis part, and in those in CKD stage 1 and 2, the risk of ISRD was reduced to the tune of 84%, and that is what you see on the right hand side. And of course, the median of 5 years, there was a 21% reduction in the nephropathy in the intensive arm of the advanced trial, again which is very, very pleasing to see that anti-diabetic is doing that significant reduction in the nephropathy part. And just to tell you, different SUs, the dose modifications in the end stage renal disease, as you can see, the gliclazide can be given with caution, and of course glipizide, which is a short acting one, another only 2 sulfonylureas can be tried when you have a end stage renal disease. And of course, there is a lower risk of doubling of creatinine vis-a-vis the glimepiride. So the gliclazide was associated with a lower risk of doubling of creatinine in patients with preserved renal function as compared to glimepiride. So in this, there are about 4,486 patients treated either with glimepiride or gliclazide for more than 2 years, and they followed up to 5.5 years, as you can see there. And this is what the result is, the lower risk of doubling of creatinine was seen. This is another one which is a real life kidney outcomes with gliclazide and glimepiride add-on, and you can see 76% lower risk of ESRD in this group of gliclazide versus glimepiride. This was in South Korea, Seoul, where about 2,800 patients, retrospective real life observational study clearly showed, and it mimicked the previous RCT which I just showed you, and the real world study also reiterates the fact. And this is another paper which talks about comparative effectiveness of gliclazide modified release versus the sitagliptin as second line treatment with metformin monotherapy, and I'm sure all of you know the results. And this is the comparison with the DPP-4. Definitely this outscores, and you can see the conclusion that the second line gliclazide was more effective in reducing A1C vis-a-vis the sitagliptin with reduced events of and low risk of hypoglycemia as well. Thank you very much for patient hearing. Any questions, I'll be very happy to take.